So it's my pleasure to start by introducing Dr. Searles. He's has quite a list of accomplishments, but I realize that most of you probably already know that because he's touched your life in some way. He's been an educator for over 30 years. He's the program director at SUNY. He has lots of ECMO experiences. He loves to educate. He does simulation and safety. And if you know him, he's just a really good human. So it's my pleasure to welcome him to talk to us today about the fundamentals of cardiopulmonary bypass in perfusion, pediatric perfusion.
So before you come to these things, I ask you, could you write a bio? So I wrote, he's a really good human. And it worked. She said it. It's fantastic. It's a great honor to be here today and to speak to this group. I especially like the 35 of you that stayed for the afternoon. But I would probably, let's see, I guess I have to do disclosures. Let's follow the slides first. I have no disclosures, but I am curious. How many people here are pediatric perfusionists? You can't raise your hand twice. All right, so that's good. We probably have like 50% of the people in the room are pediatric perfusionists. We'll try and keep it relevant, and I'll try and knock it off on any kind of a tangent. What we are going to talk about today is simulation education with regard to pediatrics. So there's a couple of SUNY grads in the room here, and you might not recognize this, but this is Silverman Hall. Silverman Hall was a city hospital. It still had patients in it in the 1930s. They converted it to an educational building, and they remodeled it entirely over the last 2 years. So now we have amazing facility. This is one of our simulation rooms. We have 2 operating rooms like this and a 4-bed ICU. It's ridiculous, isn't it, Rich? Whew. Is what? No concrete cinder blocks anymore. I don't see cockroaches running across the floor. It's nothing like you would expect in a state institution. So I pinch myself every day I go to work. I'm going to do the last 10 or 15, 20 years of my career in this fantastic facility. And that brings me to, we do a lot of simulation for training perfusion skills. And we had an interest in learning in teaching pediatric perfusion. So the way you go about building a curriculum is to understand, what is the desired outcome. We'd like to know. In this case, we would like to teach competency of pediatric perfusion skills, and particularly the fundamental pediatric skills, and how are we going to assess it? Step 2 of writing a curriculum. We're going to use preclinical and simulation. So put them in that environment. We want them to reach a certain level of competency before they ever touch a patient. So with those in the background, then you say, well, how would I build a curriculum so that I could assess it in this environment and to that standard, which then of course begs the questions, what are you trying to teach? And this is what we didn't necessarily know. See, the dialogue is that pediatric perfusion is a specialty, so I couldn't just assume that what we are teaching with our larger circuits and larger reservoirs and bigger pieces of tubing and larger clamps is necessarily, it may fall short. So we did a survey. We set out to understand from the perfusionists in the community, the pediatric perfusionists in the community, what the fundamental skills are. What do you do when you go to work? And look at the part there for deconstructed subsets. What do you do when you go to work, and how do you do it? What are the little elements? If you initiate bypass, what are the 5, 10, 15, 20 things that you do when you initiate bypass? What is there tremendous consistency about? So this is a paper actually that was the thesis work of Isabel Sentner. So shout out to Isabel if you're online here today, or anybody at the USC Keck School of Medicine. By the way, I just read online that this university is going to be opening a perfusion school on the West Coast. So congratulations to them and best of luck. It's going to be a great asset to the educational portfolio of our country. So this is Isabel's work. What did we do? Now, one of the things that Isabel did above and beyond what some of our other survey papers did is that she threw in this middle step here, which is very impressive to us. So, of course, you talk to subject matter experts when you write a survey, and you make sure that the content that you expect and need on that survey is on the survey. But she found this other thing which solves a certain problem that's common in surveys. Now, you've probably all filled out some surveys at some time, and you're uncomfortable answering a question here or there because you think, I don't know what they're asking me. If they're asking this, I would answer it this way. If they're asking that, I would answer it that way. I don't even want to answer this question because I don't know how it's going to be interpreted. This Quaid tool, which if we blow this, can I blow this up? This Quaid tool is questions and understanding aid, goes about the process of you submit your questions into this online tool. It digests your sentence and says, people will more generally understand what you want if you rewrite it this way. So we were happy that she discovered that and put all of our questions through that so that we can be pretty consistent. We're pretty confident that when people answer the question, they're answering the question we wanted them to answer. And then, of course, after getting the expert consensus and fixing all the questions, we ran it through a beta test and before we distributed it widely. That survey was distributed through REDCap, just some tool for distributing surveys. And ultimately, we put in front of people a proposal that there may be 23 fundamental skills associated with pediatric perfusion. This all comes from the idea that, as a program director at the end of the curriculum, at some point, we have to check a box for the American board or a university. And the ACPE in particular has a list of 4 or 5 fundamental summative measures is what they call them. So in many of these documents, there's this little sentence that says, student is competent at cardiopulmonary bypass. And we've always thought that that was insufficient as to take the entire thing that you do all day and boil it down to just competent at, all that. So we have been proposing through our research that cardiopulmonary bypass is actually a portfolio of skills. And in this case, for this research, what we proposed is there was 23 fundamental skills. And then to do those 23 fundamental skills, we proposed to the people taking the survey that there may be as many as 291 items necessary to conduct those particular skills. And that's what we were going to research. Here's a list of the skills that we put in front of the survey respondents. And it should be everything that you do in the course of operating a case, starting from reading the case, reading the patient's chart and collecting some data, doing some calculations, using the calculations to select some components and setting up and priming the components, doing a checklist of that circuit and managing anticoagulation, et cetera, on down all the way to the end. And do you have good etiquette and do you wear your PPE and take care of yourself and others? So that's going to be the content of that. Now, for every one of those 23 bullets that are on that slide there, the questions followed this kind of a format in which there was these 4 steps associated with answering the question. And first we ask about frequency. So for instance, in this particular question, which is just representative of all of them, how often do you monitor and manage MUF during pediatric bypass? And they have to choose somewhere between 0 and 100%, but there's only 4 measures in between there. And this is how we're going to assess the frequency of use. Next, after every question, we go on then to some assessment of patient harm. Hey, by the way, if you do this incorrectly, could the patient be harmed? And that's our assessment of risk. And now that we're talking about this particular skill, we proposed a bunch of things that might be involved in doing that and left an open-ended comment at the end in case we left something out. So if you think it's really important when you're doing MUF to do something you didn't list there, we want you to write it in at the bottom. And those are the deconstructed sub-elements. Now, since nobody had done research like this before, we get to make some stuff up. And that's one of the fun things about research. And what we invented was this thing called the 50% rule. And the 50% rule is how we're going to determine if something is fundamental or is less than fundamental. It's a skill, but it's not the most fundamental thing. So the 50% rule says that something will be fundamental if more than 50% of the respondents say that they do this more than 50% of the time. And if more than 50% of the respondents say that if it's done improperly, somebody can be hurt. So we assess frequency and risk. If it's above more than half the time, then we're going to call that a fundamental skill. And it's kind of arbitrary. We could have set that measure anywhere, but we wanted to capture as many things that you do on most of the time. The survey was distributed through all the typical outlets, and here's who participated in that survey. We had 125 surveys to analyze when we were done after we got rid of outliers of people who didn't complete questions or or people that don't pump peds, for instance. We had to pick out some of the chaff and to get to the good seed. And if you look at how the respondents are distributed across the USA, it fits pretty well with where the American board says that we hang out anyway. So we think this is geographically pretty representative of the USA. There is also 33% of the respondents from outside the USA. So that's a pretty decent participation from non-USA people. The particular employment position of these people are staff perfusionists and chief perfusionists, mostly staff. It's generally good. There's more of those people. So this seems to match the workforce in general. And we have a number of people that teach perfusion. And also, I think this is valuable for your community to understand that 35% of the respondents have their FPP. So some of the most experienced and well-studied perfusionists in the community. Additionally, if you look at the years of experience of the people completing the survey, you find that if it's, oh, I'm using my mouse, but you're not seeing it. 1 second, please. There we go. We divide up into pretty nicely, almost in thirds, people in their first decade, second decade, and third decade of their career. And if you take the demographics of what kind of cases they are involved in and draw a line over here, you get about 68%, this larger part of the pie, about 68% of the people participating suggest that they do more than half of their cases. But another fun way to divide this up is like about 45% of the people that are involved in this do both peds and adults. And they may actually be some of the most qualified people to comment on the differences between the two if we were to ask that question later on. So what did we define? What did the people tell us about the questions we asked? This is really the big summary slide here. 22 of the 23 slides of 10. She gave me a 10. Is that minutes? Oh, crap. Okay, 510. All right, we're gonna wrapping up. We have 22 of the 23 skills were accepted as fundamental, and of the 291 individual little subsets, so we suggested there was a large amount of consensus around 258 of those. So we scored a lot of data here that we can use for our purposes, which is writing curriculum. If you break that down into a nice little table here, you'll see that we've got all these individual skills that I told you about before, and this is the kind of the frequency with which the survey participants suggested. And it's really, really high. So this is very strong comments that I do this almost all the time. And there is near universal agreement that, and if I do that wrong, somebody gets hurt. That really fits the criteria of being fundamental. You better be able to do that stuff, these 23 things, if you're going to operate a heart-lung machine. Because if you don't do it well, someone's going to get hurt. It's going to be asked of you very frequently, and it's dangerous. So everything on that table is accepted. And if you look at like the 31 things that we suggested go into possibly doing, what kind of data do you look for and what kind of calculations do you do? The community respondings agreed on 25 of those 31 things. So now I've got 25 little items that I can write into curriculum, and I can grade through my rubrics with regard to this skill right here of data collection and calculations. And that's how you read this table this way. The second half of that table gets us to the only deviation in the data, and that is there's a category of ultrafiltration that was blown up into 4 different flavors of ultrafiltration. And you see continuous ultrafiltration. Everybody does it almost all the time. But there was a little bit lower responses to pre-buff and muff. And this, by 1 percentage point, didn't make it into the fundamental skills category. We just needed probably 1 more person. 2, if it's a 50-50 chance, maybe 2 or 3 people. He could have voted twice, for instance, if he had used 2 IP addresses, and we could have maybe gotten this one across the line. So it's really close. It's hard to say, but we set the cut at 50%, so reject, not a fundamental skill. But we know a lot about the things that go into these skills. So what can we do with data like this? Well, now I have 22 fundamental skills I can put into high fidelity simulation curriculum, and we can write a curriculum to introduce them to students in a logical way and test them in the simulated environment. And the things that we're going to test them on are those 258 things that you told us are important measures of that skill. And if you look at those kinds of those elements that you told us about, then you'll find that they fit into the 3 learning domains that are necessary: the psychomotor, the cognitive, and the affective. This doesn't represent all of them, but nicely, they're not all technical skills. Communication is in there. This decision-making and thinking and knowledge base is in there as fundamental skill. This isn't a technician manual that we're trying to put together. So what's next? Well, the next thing is there's going to be elements. You told us about skills like managing blood pressure, but we didn't ask you in this survey, well, what blood pressure? And that is something that we've done for the adult community. We have this survey of routine practice limits and physiologic and technical parameters managed by clinical perfusionists during adult cardiopulmonary bypass. We need to rewrite that paper and resurvey your community again and find out pediatric-wise. And this will be a little more complicated because we'll have to break that up into neonatal, small peds and large peds. For instance, but that's a necessary element too, as far as I can teach you to manage blood pressure, but I also want you to teach you to manage the blood pressure within the range that the clinicians expect. What else did we learn? Well, we now have, although it wasn't necessarily the point of the research, we have this opportunity to look for how much overlap is there between pediatric skills and adult skills, because we have a finite amount of time to teach. We have an infinite number of things to teach. So there has to be decision-making with regard to how we're going to distribute that time. And then that puts us in a situation where you could do a direct comparison between our 2 papers. And this is the fundamental skills of adult. Now, having a smackdown with the fundamental skills of pediatrics. And let's see what happens here. You see that the surveys are nearly identical. The table 3, it's even table 3 for goodness sakes. Table 3 in both papers follows the same format, the patient data evaluation, the same list I gave you before. And if you look down the frequency column, it's pretty dang much the same data right across the board. Even ultrafiltration has a dip. Ultrafiltration was only a single category on the adults, but we blew it up into all of its multitude of flavors for the pediatrics. So that's how we end up with 22 fundamental skills for the peds and only 20 for the adults, is because we defined different kinds of ultrafiltration. But by and large, everything that's over here is also over there. We just have finer granular information about something there. So it would appear from this kind of research that these 2 overlap almost entirely, which then challenges like, well, how would I run my simulations much differently? So we have this additional then follow-up question of, is pediatrics that different from adults that it requires a special curriculum? And I want to believe some of the most brilliant minds I know about pediatric perfusion are in the room with me, and I mean no insult when I suggest. Why are you nodding your head like that, Rich? I mean no insult when I suggest. I just don't know. I want to believe. I feel it. I used to pump peds for a couple of years when I was rather young, before I got into education. So I know there's a different feel in the room. But this is now the second time that your community has sat down to identify what you do, and you came up with, well, what we do is the same thing the adults do, except we use a smaller font when we write it down on a piece of paper. So this is the standards and guidelines, and this followed the same presentation, by the way. Is we have the standards and guidelines for adult practice were written, and then the pediatric community adopted it, just like we wrote a survey for adults, and the pediatric, we then surveyed pediatrics for it. But the data you get back is very much the same. There are only 3 things that are different in the table of contents. There's only 11 new standards in the entire document, and most of those standards were just guidelines that were elevated to standard. You could have written anything you wanted, and you wrote that. So this is what you believe. I get it. I've heard conversations about, well, it's not in those things, Bruce. It's in the precision. And I just had a good conversation with a colleague over here, and he has some really good examples of how it could be precision. But then there's also really good examples on the other side where the precision doesn't work out in your favor. Like, look, my response time as an adult at 4.5 liters a minute could be much shorter than the response time you get on a pediatric circuit when you only have 50 mLs in your reservoir. So is pediatric that different from adult? Oh, this is from adult peanut butter. Peanut butter. Is pediatrics a specialty? I don't know. Some of the skills, they seem very similar. The standards are very similar. The response time might actually be slower in certain times. The physiology is mostly the same. Oh, they have so much different physiology. Yeah, I mean, hemoglobin, hematocrit, blood flow, oxygen delivery, we get all that. That's pretty much the same. It's not a new skill to put a different constant in the same formula. But there are things that are distinctly different. It's the pathology, it's the surgical corrections. And I think in here is where we need to focus the conversation, because there's something different. I believe it. I believe there's something different. But I am going to ask for your help. I want to believe as many true things as possible, and as many not true, a few not true things as possible. So can you help me? Can we have a dialogue here and ongoing with regard to identifying those things that are special so that I can teach students better? Because if we can measure it, then I can put it into a curriculum. But I can't put the feeling into the curriculum. I think that's where this one ends up. How did I do? 30 seconds over. Thank you very much. I appreciate your time.
Don't go anywhere. We're going to ask you questions, right? We're going to have our second. That was an excellent talk, Bruce.
Usually I have to leave through the back.
I know. Well, I'm hoping somebody will get up and give some thoughts on that. But I'm going to start it off a little bit less incendiary and just sort of ask, I know you mentioned, this is an offshoot, but I know you mentioned putting your data into REDCap. Mm-hmm. And data management is such an interesting topic right now, and you were able to query all of these things. Can you tell us a little bit about that system? Because I don't think a lot of people know about it.
About REDCap?
Yeah.
REDCap was kind of an open source software. It's a SurveyMonkey on steroids. So a lot of surveys that we get in our community are SurveyMonkey. REDCap is a secure system with servers that generally universities own, and it allows for really rigorous authentication. You know that the data that's coming in has been authenticated, and once it's in there, it's protected. So for instance, it's used a lot for medical research. You can collect patient care information into this. It meets all of the necessary security requirements that SurveyMonkey absolutely does not.
I understand it's really easy to pull the data out of that too, which might be why
it does have a lot of data analysis built right into it. It's not any harder to learn than SurveyMonkey. You just have to find out who do you know that has access to such an account.
Yeah. And then I'm going to turn it over here too, but I just also sort of wanted to think about, when you sent out the surveys, was there an option for people to also write in some thoughts that they had about other skills that they might want to use?
I did. I took that slide out.
Okay.
There was about 6 or 7 bullets on another slide that I culled just for time, and they were identifying, because we asked them, do you think there's any other skills? Not only did we ask for what individual sub-steps did you think we left out at the end of every question, but overall, we at the end of the survey, we said 23 things. Do you think it's 24 or 25? And there were probably about 7 things that were written in. They weren't written in by like 50% of the people. So there wasn't any overwhelming opinion. And then from the researcher's perspective, when we look at some of those things, it didn't warrant necessarily further analysis. I believe they are mentioned in the paper though. So if you download this paper, you'll see what those are.
Okay, thanks.
We have some from the online. Callie from online says, are there different levels of pediatric simulation curriculum based on interest offered, such as like basics versus advanced?
Maybe yes. You know, there's students that have a particular interest could do more than we present to them. And honestly, we present very little because the skills are the same. God, did I say that? So, I mean, if we put together a pediatric circuit, all the students will see it for a period of time. But all our simulation labs are open all the time. So I come in on Monday and I can tell that there have been students there all weekend doing all kinds of crazy stuff. So Yes, if you have an interest in our institution, if you have a strong interest in this, you can practice it an awful lot. It takes us kind of putting the equipment out and giving you some introduction to it. So there's a minimum and you can do more.
Erin from DC Children's. I think that when we're learning in school, you know, most of the time, most of us learn on adults, unfortunately. And I think that you're right, that all the skills that we need are the same. The difference comes in that spot that you have not asked questions yet. It comes in the difference of you have a patient this big, and then it gets bigger, and then bigger and bigger and bigger until you have a full-size patient. Mm-hmm. And at every single one of those incremental steps, you have to make decisions and choose things based on that patient. So when we get students that are, you know, pretty decent, they can learn quite well what needs to be done. And when we are hiring, we actually oftentimes prefer to hire students versus perfusionists who've been out for 7 or 8 years, because those students still can remember how they derived the decisions that they're making. Mm-hmm. So why are you doing this? Why are you having a lower blood pressure? Why are you giving this much drug? Why are you choosing this circuit? When you get out of school and you start doing things in adults, not everybody, and I don't want to offend anybody, but a large amount of people just start doing things because, you know, you always put 25 of bicarb. You always drop a liter of fluid. You always do this, you always do that, and they forget why they're doing it. So to have the education being with pediatrics, if we could teach everybody like such a long time, so much more time in pediatrics, they could then become adult perfusionists so much easier. Mm-hmm. I personally believe that any pediatric perfusionist can be an adult perfusionist. The opposite is not always true. Because you have to be able to pay attention to those details. It's not necessarily reaction time. It's not necessarily being quicker or more aware of things, because our circuits are smaller, so we need the same amount of reaction time as a big person does when they're flowing 4.5 liters, while we're only flowing 300 liters, mm-hmm. but my level detector is at 30. So, you know, it's a huge difference. But it's learning why we're doing the things that we're doing. I think that will provide the most impact with teaching them how to do pediatrics, aside from the obvious of what the surgeries are and why those surgeries are needed.
I appreciate the comment, and I agree entirely. And I perhaps am influenced by, you know, my particular position. So when you suggest, well, there's all these more calculations, I have to think about it for every case, I think, well, that's just the first 5 weeks of perfusion school. You know, we bring students in and we teach them, oh, by the way, a heart-lung machine has components. Components have ratings. Ratings are based on blood flow. Blood flow is based on BSA, which is heightened. So you have every single day, they're doing exactly what you have to do every single day. And I totally agree that after you leave the university and go off and there's only one pack on your shelf, you stop doing the math because, well, I'm going to pick that pack. Even if you did the math, I'd pick that pack. It's the only pack I have. You get a little tiny woman, I pick that pack. It's the only one I have. So the first 5 weeks in perfusion school, every written case is a patient of a different size. And we have pediatric, specifically on your very first test, demonstrate with pediatric cases. I agree with you entirely. It's a fundamental skill. And we use PEDS to introduce this whole concept. Thank you. Thank you very much.